I started using RayOne EMV about half a year ago, and my initial experience was rather to try with targeting emmetropia. I wasn't very easy user of monovision in the first patients, but later on, when I was convinced how the EMV works, I was more likely to start with high range of monovision, extending the depth of focus properly in those patients. So it's basically two different periods of use for the EMV. The first one where patients were more likely to target emmetropia, and later on for bilateral surgery, and I'm using mostly same-day bilateral surgery. I've been using the emmetropic approach for dominant eye, and about 0.75 to 1 diopter of monovision for the non-dominant eye. So my first observation is that the EMV lens gives extremely easy adaptation, and it's very similar to what we see in monofocal patients when it comes to the post-operative period. So there's no learning of how the lens works. There is a little bit of learning how monovision works, but generally the lens behaves exactly as a monofocal lens in terms of the direct postoperative period. And when it comes to the neuroadaptation, it's absolutely different approach than we have with monofocal lenses. So it's very easy to say that when you compare the monofocal group to the RayOne EMV, it's more or less similar in terms of adapting to the postoperative period. So first of all, I guess it's very important to mention that it's not just a lens for bilateral implantation. It's not just a lens for bilateral emmetropia. It's the lens both for bilateral emmetropia and for monovision approach. And at the same time, it's a perfect lens to operate patients where you have cataract only in one eye. So it's a very universal approach with very different potentials in very different eyes. Currently, about 60% of my IOLs are multifocal and extended depth of focus, which means that I still have about 40% patients to manage with monofocal approach. And I'm still not happy with so many patients being in the monofocal group on one hand. And sometimes when you consider the multifocal patients, you think that the negative characteristics of patients' behavior gives you potential risk of using multifocals. So there is a general tendency to move in such patients towards safer options. And I guess monovision with RayOne EMV is a perfect approach and perfect target in those patients. Because then you can consider the adaptation period being similar to what we have in a group with monofocal lenses. So I would still say that even for the premium surgeons, it's still like 40 to 50% of patients who can be extremely good candidates to implant EMV. But at the same time, for surgeons using only monofocal lenses, still there's no transition towards what EMV gives you. There's no like direct indications which would be different for EMV than you find with monofocals. You can go with the same approach as you go with your monofocal lenses. There is a major difference between EMV and the monofocal group, which I was using, and at the same time, it is different from multifocal lenses. On the other hand, so the first and major difference for me is what we can achieve with only one diopter of monovision with EMV, and that's about 2.25 diopter of depth of focus. which gives you spectacle-free independence, which is safe for both distance, which is very good for intermediate, and only what is important in those patients to consider the near vision correction. At the same time, especially in patients who might be potentially problematic with the dysphotopsia, there is no pupil dependency. So especially in patients with large pupils or extremely small pupils, where the peripheral zones with near vision might be a problem, then there's absolutely no problem to consider the alternative with EMV and go on with implantation in those eyes. At the same time, as we all know, there are lots of problems when it comes to especially multifocal lenses in low light conditions. And for this reason, in many patients driving at night and patients who are working at night, we see that the satisfaction levels after the surgery, with especially with multifocals, is not perfect. So we're trying to find out what would be the most suitable option for those patients, still preserving as much of intermediate vision as possible. Generally, as I mentioned, I can see my transition towards the extended depth of focus or monofocal plus options, which are generally safer in many of my compromised patients. I mentioned patients with negative characteristics. I mentioned patients where potentially the dysphotopsia might be a problem. But at the same time, you have many patients who say, "Doctor, I don't really have a problem with using reading glasses, but it would be very useful to have safe intermediate distance." And then you can consider those patients being a perfect group to consider EMV with monovision. But at the same time, it's not just taking off patients off the multifocal group. At the same time, it's moving the patients from the monofocal group towards a slightly more intermediate distance, and giving those patients more spectacle-free, especially when it comes to the distances like 65, 70 centimeters, even without monovision. So I guess it's a very easy approach when it comes to one eye surgery, when you don't have to consider monovision in those eyes. And sometimes you have younger patients only with one eye, with post-traumatic cataracts, where you know that potentially halo effect or glare might be a problem in those eyes, especially if there is a little bit of tilt within the lens, and so you have to consider post-operative vision. Then I think lenses like RayOne EMV might be a very good solution to manage post-operative vision. I'm definitely very happy with what I achieved with RayOne EMV. First of all, you have to understand how this lens works. You need to understand that a little bit of monovision is probably your best friend when it comes to inducing more in terms of intermediate, when it comes to less spectacle dependence in those patients, and it doesn't compromise the distance vision in those patients. So if you just explain to the patient that both eyes will work in a slightly different way, that comparing those eyes doesn't make sense, and it shouldn't happen after the surgery, I guess you have a very cooperative patients at that time. And finally, it means that after the reasonable postoperative period, we are achieving very reasonable and nice intermediate vision, at the same time preserving extremely good distance. Thank you.